Well, good morning, everybody, and welcome again to, well, this time to the conference. 2 days talking about big biobanks, the ethics and governance thereof, past, present, and future. The EGC has been in existence for 10 years. Seemed like a good time to take stock. And in taking stock, it is a question of looking back, looking around today, and thinking forward. If we were talking about the past, it's 10 years. It's not a long time, I think, in biobanking. A great deal of that time has been taken up with bringing participants into the project, 500,000, and setting up the systems. It's only for the last 2.5 years or so that the resource has actually been open to the research community for research use. So we're still, I think, in our infancy in relation to experience with access and applications into the resource, although we are learning very quickly about the volume of applications and the kind of research uses that are being applied for. Then there's the present. Now, Alistair Campbell, in his brilliant lecture last night, alerted us to the way in which the present is here today and gone tomorrow. And I think particularly struck by the graph that Alistair showed of the way in which the costs and the time taken to conduct sequencing are coming down. I mean, it's something analogous to Moore's law in information technology applies to sequencing, then it's not going to be too long before sequencing is almost as cheap as getting a cup of coffee and probably can be done quite a bit more quickly. So the future is already, I think, present in the present. I mean, my sense is that people of my generation understand that the present is different from the past, but also, I think, sense that the future changes the present more quickly than ever before. It's extremely dynamic. And looking forward, well, it's not only the science and technology that's going to change, no doubt the ethics will change as well. And for the EGC, there are questions about whether our role should change. And one of the main purposes of this conference is to at least open a conversation about that question, because up to this point, quite rightly, I think, all our energy, all our focus has been on the internal governance of UK Biobank. The Ethics and Governance Council is there for UK Biobank. It's questions about governance of UK Biobank. So it's inward looking. But of course, we have visitors from other biobanks. We talk to people elsewhere about biobanking, particularly about big biobanking. And there's a question about whether we should try to do this a bit more systematically. In other words, should we be, as a council, rather more outward facing? And we'd be very interested indeed to open a conversation about that kind of question. We don't have a clear vision of what that might involve, but is this the right time for the EGC to begin to develop some sort of outward-facing profile? So I hope that over the next 2 days, we're able to engage with some of the hottest questions in biobanking, as well as think about the governance issues today and into the future, and the role of the EGC. But we start off in the best possible place with a presentation from Professor Sir Michael Rawlins, who is the chair of the board of UK Biobank. And may I say, well, let me just explain that the relationship between the EGC and the Biobank board is that the council, like the board, meets quarterly. I wouldn't say there's a perfect synchronization between the meetings of the council and the board, but generally speaking, the board meets later on in the month and the council meets earlier on in the month. We formally report to the board. There's a standing item for reports from the EGC. They are pretty short reports. They are really largely for information. So that's the formal state of it. But the buck in the end stops with the board and with Mike, who is the chair of the board. So, Mike, over to you. Thanks very much indeed.
Thank you very much. It's a great pleasure to be here, and I was asked to sort of give an overview of Biobank and its development and its future strategy. Biobank was set up by a group of funders, the Wellcome Trust, the MRC, in those days the Department of Health, now actually the National Institute for Health Research, the Scottish and Welsh governments, the British Heart Foundation, and diabetes to the UK. And they came together and established Biobank as a charity in 2003. In 2010, the charity set up a commercial arm, BioCentre, to store samples for other organisations. For example, the British National, the NHS Blood Transfusion Service wanted us to store samples for them on their behalf, and some commercial organisations have asked us to store samples for them. And so it's a little profit centre, and it gift aids back its profits to Biobank. UK Biocentre has an independent board, independent chairman, and as they say, as I said, indicated, they report back to Biobank. And then about 18 months ago, the National Institute for Health Research asked us to establish a storage facility for the academic biomedical research centres, biomedical research units around the country, and gave us a substantial sum of money. For complicated reasons, it was actually laundered, as it were, through Oxford University, and we're in the process of constructing a separate storage facility for academic research samples, nothing else. It's expected to be a break-even operation. It's not expected to make money but it's a resource for the academic community in the UK. I'm not going to say anything more about BioCentre and BioResource, but if you want to know more, I'm more than happy to talk about it. As you've already heard, there's a board. The board consists of me, some independent members, and representatives of the main funders. The chief executive and principal investigator, as he's called, is Rory Collins, who's not able to be here this morning because it just so happens that he has a meeting of his international advisory board, scientific advisory board this morning, but he's coming this afternoon. The deputy chief executive is Tim Peatman, who's been the genius behind the construction of all the storage facilities. Premises we have in Cheadle, in near Manchester, where we have the sample storage arrangements. The samples are stored in a very sophisticated, robotically controlled environment. But it's not just any sample storage in Cheadle. Quite a lot of the workup of biomarkers, some of the analyses of biomarkers, the DNA extraction, and some of the access arrangements are run out of Cheadle. And then in Oxford is with the data storage, but there's more than just data storage at Oxford. There's also a lot of other operational issues. So it's quite a substantial setup with two centres. And the BioResource, the Centre for Storing Academic Samples, is a new facility which is being constructed in Milton Keynes. And we have a range of advisory groups. Some of them are subject specific, and we have the International Scientific Advisory Board that I've already mentioned, which explains why Roy is not here at the beginning of the day. So this is the timeline. Biobank was established in 2003. There was a setup phase, got quite complicated in relationship to building the storage facilities, making sure it was robotically controlled, and then the recruitment phase. Samples from each of the recruitment centres, and I'll show you where they were in a moment, were sent back through Cheadle overnight. The samples are spun down. One robot took a photograph and told its next door neighbour how far down to put the pipette to get the plasma out, how much further to get the white cells, how much further to get the red cells, and so on. It's a very, very sophisticated arrangement. And then an access started in April 2011, and you'll be hearing much more about the access program tomorrow. We had, as you can see, we had these recruitment centres across England, Scotland, and Wales, and we recruited just over 500,000 participants. It's actually we recruited 5,000 more than we originally intended, but that's no harm done for that. We needed a large number for this very simple reason. If you wanted to look at the relationship between systolic blood pressure and cardiovascular events, in various age risks. You can see that if you have 5,000 people, well, you can't really interpret anything from that. With 50,000 people, there's still a lot of overlap. If you have 500,000 people, then you can see a very clear relationship between blood pressure, cardiovascular events, and age at risk. So that's why we needed such a substantial number of people. I keep on bumping into biobankers around the country when I say I'm chairman of Biobank, and they say, oh, I'm a biobanker. And what's interesting is, to a man and a woman, they're very proud of being biobankers. And I understand from Bill Lawrence over here that the framing of people have a little pin badge, so maybe we ought to get pin badges for our biobankers to wear and to promote their pride in being part of this, this extraordinary venture. At the initial assessments, they consented to participate, broad consent. We had a baseline, electronic baseline assessment questionnaire. They had baseline measurements of all sorts of things, but height, weight, blood pressure, ECG, intraocular pressure, spirometry, and so on and so forth. And there was collection of blood, urine, and saliva for subsequent use. All participants have been, as many as possible anyway, have been followed up. We have completed death and cancer registries, and we get all that, and inpatient and outpatient hospital episodes, what we call the HES data, the hospital episodes and statistics. And we get that. We are in the process of getting primary care records. That's more complicated, actually, and there are all sorts of things about it, but we are getting those gradually in place. We are enhancing the data, and we've done a web-based assessment of diet. This shows the way it was done. It was quick and easy. Over 200,000 participants completed the questionnaire at least once, and 90,000 did so more than once, which helps us with reproducibility. Further data enhancements, and I'll describe each of these in turn. Risk accelerometers to all participants who agreed to wear one. We're undertaking a standard panel of assays on samples from all participants. We're genotyping all participants. And we are planning, and we've started doing multiple imaging of 100,000 participants, more of those in a moment. So this is the risk accelerometer. You can see up there the thing you wear on your wrist. 45% of participants agreed to wear one. They were sent the device by mail. They wore it continuously. It's waterproof. You could take it in the shower, in the bath. We get them returned, and we get over a 99% return rate, which is quite helpful, because we can clean them up and send them to somebody else. And this is the sort of track you can get from it. And we expect to have 100,000 participants wearing these wristbands, accelerometers, before the end of the middle of next year. We've got a lot of biological samples for all sorts of assays, and as I said, that's going on at the moment. We're genotyping. We got the two famous genotyping organisations to bid head-to-head for the contract to do the genotyping. I won't tell you how much we had to pay, but apparently we got a very, very, very good deal from them. And Affymetrix had developed a genotyping chip for us, 250,000 SNPs, 200,000 markers for known risk factors, and 150,000 exome markers. And we will be imputing additional genotypes with reference sequence data with the help of the Sanger Institute. And then we are also starting to do MRI scans. We want to look at DEXA scans and MRI scans. And DEXA scans, because of the difficulties actually of interpreting DEXA scans in relationship to men in particular. Curiously enough, it's worked out reasonably well for women, but for men, it's uncertain. But we also want to look at it for other reasons, one of which is, for example, the amount of internal fat. And you can see these two people, MRI scans of two people who are the similar age, gender, BMI, but they have different amounts of internal fat. and what is the relationship between internal fat and risk factors for various conditions. So this is one of the reasons why we're looking at doing MRI studies. In fact, at the moment we're doing a pilot of 5,000 to see what we get, because of course we're doing MRI scans on what are essentially normal people, and we don't know quite what we'll get. We're planning a repeat of cognitive function, partly to repeat the assessment of the baseline measures, but also to broaden the cognitive phenotyping with new measures. We are looking to develop occupational histories for all the participants, and also to do a physical activity questionnaire to complement the data from our activity monitors. And we've got further enhancements under discussion, and this is quite tricky, but it has been suggested from international colleagues that we ought to looking at perhaps helpful to look at the panel infectious diseases in the baseline sample, not least of which to see if relationship between these conditions and the subsequent development of, for example, malignant disease. And we're also planning to screen for cardiac arrhythmias, especially atrial fibrillation. That's more complicated. It's not just a matter of a single ECG. You've got to do it over a prolonged period of time, because some people have atrial fibrillation that comes and goes. So what makes biobank special? Well, it's prospective. It can assess the full effects of particular exposure or risk factors on all types of health outcomes. It's detailed, a wide range of questions, measures of samples at baseline, so we have good assessment of exposure. And it's big. We've got a large number of participants, allowing a reliable assessment of the causes of a wide range of diseases. And so UK Biobank is already an unprecedented resource for health research, and with our current and planned enhancements, and with the passage of time as the participants grow older and get things, its contributions to public health become even more significant. So thank you very much indeed.
Adrian here has the roving mic. Anybody like to, I know there's a tendency here to discriminate in favour of the front, but does anyone from halfway back want to ask a question?
Come on.
Okay, let's try it.
Oh yes, there's a bit. Lady there.
Yeah, oh, sorry, Martha. Yeah. Okay, we'll start with Martha and then go from there.
Thank you very much for your presentation. Have you received any feedback from your participants in the MRI enhancement as to their continuing appreciation that that this is not a diagnosis, but actually
it's
an
a
assessment? Yeah.
However, yes, we're doing actually quite extensive sociological research, because basically, if we find something and the radiologists think it's treatable, then we tell the GP and we tell the patient to go and see the GP. And we're doing a very, very careful follow-up onto the consequences of doing that for the first thousands. You're quite right, it's very important. We need to make sure that they are comfortable with what's happening.
Thank you so much. That was very interesting. Just a question about the past. You mentioned in passing that you had a broad consent.
Yep.
When you first started. Can you sketch in a few words how broad that was? And
yes, they agreed to allow their the data, anonymous of course, and whatever findings were found, not to go back to them, but to be used purely for the purposes of research. Now we have made a bit of we have changed it slightly in terms of the imaging, because we didn't feel, you could see a glioma in somebody's head. You can hardly say, oh, how interesting. I wonder how long that will take before it presents. You can't do that. We have a duty of care. There has been suggestions we should reconsent. That, frankly, would destroy the entire database. And it would waste £160 million, which was constructed, because we can't get back to them all. And what do we do about the ones who are dead, and so on and so forth. I mean, we've got email addresses for many of them. I think it's up to about 2/3, but but we can't reconsent. And that's why we were very worried about what was going on in the European Parliament about this. Because they'll destroy us, basically.
A small question. How many consents have been withdrawn since the start of the project?
I have no idea. Actually. Mike Parker, you're there. How many withdrawn, do you know? Tiny. I don't know. I don't know. They always, right from the beginning, they had the opportunity to, they can always withdraw. But it's tiny. Yeah. And
Andrew Traherne deals with that, doesn't he? He said
yes, where is Andrew?
You can,
one can imagine many other studies, such as digital dermatological scans and so on, that could be done. How is it decided which assays or what kinds of tests are to be performed? I imagine that's a
Well,
process.
it was a bit of a compromise. I mean, one was we only had a certain amount of money, so we can't do everything. So we had to balance the cost versus the value, and so we chose the 41 analytes based on that. I mean, some of them obviously electrolytes. I mean, obvious, but some of them were rather expensive, and so we couldn't do all the ones we would have liked to have done. But we can come back if we get a bit more money.
Well, you just mentioned cost benefit, so that was somewhat my question. You said that there were 2 organizations bidding, but this is a significant portion of your cost. So in terms of the whole venture of doing biobanking, how much is the cost of the DNA sequencing part?
Well, I don't think I can tell you. We got a good deal.
Okay.
A very, very good deal.
Well,
both
okay.
organizations were keen to have the prestige of doing it.
But as the price goes down, you would perhaps think even more in terms of 50
whole
years
genome
from now.
scans, yes, in 5 years' time, we might do that. Yeah.
Okay,
Yeah.
thank
But
you.
at the moment, we're doing genotyping. Yeah.
Genotype.
Yeah.
Thank you very much for the talk. Bartha asked you about the issue of clinical feedback in relation to imaging. Is the answer that you gave for that equivalent for the issue of genomics? Because I know that in genomics, your actual consent form said you wouldn't feed anything back in that. So how are you planning to deal with that problem?
No, we're not. We have no plans to feed back, and that would be extremely difficult to begin to contemplate doing it. For example, I don't wish to know that I have the Huntington's disease gene, and 85%. Quite interesting, Huntington's disease. 85% of people with Huntington's don't wish to know, even though they know they're at risk, 50% risk. And it's quite interesting that Jim Watson, when they did his whole genome scan, he asked them to remove the bits that would tell him whether he was going to get Alzheimer's.
Okay.
there's one more over the, I can see one more.
Just linking together 2 questions. You mentioned a duty of care to feed back the brain imaging.
Yeah.
What legally is the difference then in duty of care to do with the genomics and the genotyping, in your opinion?
Well, I'm just an ordinary doc, and I'm not a lawyer.
Maybe perhaps from
so I'm
legal
not
advice.
thinking about duty of care in a legal context. There are lawyers here who can tell me what the legal position is. I'm doing it as an ordinary, reasonable human being. You know, and if we found somebody had a glioma, a small glioma, we couldn't just leave it. So treatable things. On the other hand, if you've got a bit of cerebral atrophy, you don't really want to know, do you? I don't want to know that I've got a bit of cerebral atrophy. Bill doesn't want to know he's got a bit of cerebral atrophy either. So we've got to be a bit sensible about this.
Yeah, I think that my question relates to this because I had...
Sorry. Go ahead.
I'm very petite. I have this very interesting patient in our small biobank who argued with me about the anonymization of her data because she wanted to know if she has anything, and she wanted to pledge for the right to know, because we are doing some analysis and we maybe share the data with other colleagues, and the data will be, the samples will be anonymized. And she wants her samples to be de-anonymized. And I found very interesting from the ethic point of view. I think that it's something that it's a kind of challenge that we have to face at some point.
The deal with the biobank would be there would be no feedback, and if people wanted feedback, then they wouldn't be able to participate. I mean, that was the deal. And if they want some other sort of screening, then they can go and see their doctor about it. Yeah, yeah.
In the information sheet and everything, they know that the data in the samples will be anonymized. But she was just making a point.
Yeah, yeah. Well, I don't recall any participant asking for any details. Did you?
No, no. One more question, maybe? Oh, Bart's got another one? No.
Thank you very much for your presentation. I curious about whether you have a plan for your communication with participants, or how do you know whether how do you know what participants feel or think about what you are doing? I mean, in terms of processes.
How do we know what the participants' views are on how does biobank?
Yeah, well, we have contacted them in as much as we can about what we're doing, explaining what we're doing, and of course one of the proofs is in the pudding, in the sense that so many are coming forward to help us enhance the database. So I think that's specifically. But the difficulty is that we can get hold of, and the ones we've got email addresses on, some of them will have moved, some of them will have died. So, you know, recontact is quite tricky. And as you'll hear tomorrow, some of the people wanting access want to make recontact to find out bits and pieces. And we're very, very cautious about the recontact, particularly recontacting those in whom the recontact would in itself tell them something about their health status.
Okay, I think, Bertha, did you want to have one more supplement? And then I think we probably make this the last one.
I think it's on point. We have a 300,000 cohort in Canada, similar rules, everything as established about 10 years ago. But with the researchers accessing with particular studies that are more clinical and less resource biobank longitudinal, that creates a clinical relationship which we have nothing to do with. Eventually, the enriched results go back to the biobank. But we have found that our clinician researchers accessing often do have limited return policies due to the information that they see that they cannot ignore.
Thank you.
Well, thank you very much indeed, Mike. Thanks very much again for that. Thank you.